It's time for the Delaware Valley's first radio doctor.
On call every Saturday afternoon at 5.
This is Your Radio Doctor with Dr. Marianne Ritchie.
Presented exclusively by Independence Blue Cross.
Your health determines your life, your longevity, and your happiness. Let your radio doctor lead the way with your medical education. Your Radio Doctor, Dr. Marianne Ritchie.
Good afternoon and welcome to Your Radio Doctor. I'm your host, Dr. Marianne Ritchie. Happy New Year to everyone. I hope you all had a joy-filled holiday and found some time to rest and relax with family and friends. I also hope you made it through the first visit of the season from Jack Frost earlier this week. Fortunately, Old Man Winter didn't send quite as heavy a snowfall as predicted, but remember, winter storms bring two enemies, snow and ice. That's why I thought to start the year, our first show would focus on common injuries of the shoulder, some of which can occur during shoveling snow. Joining us today is a surgeon of international renown, Dr. Gerry Williams, from the internationally recognized Rothman Orthopedic Institute here in Philadelphia and Florida. Dr. Williams is the John M. Fenlin Jr. Professor of Shoulder and Elbow Surgery at the Sidney Kimmel Medical College of Thomas Jefferson University. He's also the chief of the Division of Orthopedic Surgery at the Mainline Health System. And his reach extends across continents through more than 200 articles, multiple book chapters, 4 textbooks. He served as the president of the American Academy of Orthopedic Surgery, the American Association of Shoulder and Elbow Surgeries, Philadelphia Orthopedic Society, Pennsylvania Orthopedic Society. This is a gentleman of many talents who must never go to sleep. Welcome, Gerry.
Thank you, Marianne. I appreciate it very much. Thanks for having me.
Well, you're a superstar, and I'm really honored that you're here. So, Gerry, common shoulder conditions and surgeries. I know that's your baby, shoulder and elbow, but you are a master of shoulder repairs and shoulder surgeries. Let's start with describing the anatomy of the shoulder because for people to visualize it, it's not dissimilar to the hip joint, but it has important distinguish. How are they the same? How are they different?
So to look at it from an overall perspective, the hip joint is a true ball and socket joint. It's actually a ball in a socket. The socket covers most of the ball, and most of the stability of the joint is yielded by that arrangement. The shoulder acts like a ball and socket joint. In other words, when you move your arm around in space, the center of rotation of the ball doesn't move with respect to the center of rotation of the socket more than a couple of millimeters. And when you consider the fact that rather than a ball and socket joint from the standpoint of bony configuration, it's more like a basketball on a teacup saucer. So the way that it stays centered is by the rotator cuff muscles pulling the ball into the socket as the motion occurs so that the rotator cuff guides the rotation of the shoulder so that in a normal well shoulder with good rotator cuff muscles and no contractures, you can put your arm anywhere you'd like to put it in space and the center of rotation stays with respect to the glenoid centered. And so the bony anatomy is the socket is on a bone called the shoulder blade, and the socket is called the glenoid, and it's at the end of the shoulder blade. The ball is on the top of the arm, which is the humerus bone. The clavicle, which is the collarbone, connects the shoulder joint to the axial skeleton through your breastbone at a joint called the sternoclavicular joint. And the whole joint itself rotates up and down on your thorax between the shoulder blade and the rib cage. The rotator cuff is 4 muscles that go from the scapula to the humerus, the socket side to the ball side, and as I said, helps maintain range of motion and stability throughout, I would say, the normal ranges of motion in life. At the very extremes of motion, the ligaments of the shoulder, called the glenohumeral ligaments, control stability. And I'd say that's it. That's the basic anatomy.
So I always, when I think of these parts of the skeleton, I think of the hip joint anyway as a garage, and the ball of the femur, the thigh bone, is the car going into the garage. And the shoulder joint, that garage is maybe built for one car as opposed to the hip for two cars. It's just a more shallow. It's shallower than the hip joint, yes? So you really depend on that rotator cuff, as you say, the T-cup, and the ligaments to keep everything in its place and keep the person comfortable and functioning. What are some of the conditions, such as use and overuse, that lead to shoulder problems or shoulder pathology?
Well, if we subtract traumatic things like fractures, dislocations, things like that, the common conditions that you see in shoulders as patients age is a combination of degeneration of the tendons and some of the things around the shoulder, in addition to overuse. And if you just look at it statistically, the most common thing by far is rotator cuff tears or rotator cuff issues. However, it can be difficult for a doctor to figure out whether MRI findings associated with a rotator cuff tear are really the cause of the symptoms. So I'll give you an example. Let's say that you see a 75-year-old person in the office who has shoulder pain and they have an MRI scan that shows a small full-thickness cuff tear. If you were to take 100 people that age off the street that never had a single day of shoulder pain in their entire lives and you did an MRI scan of their shoulder, probably 30 of them would have small full-thickness cuff tears and not even know they had them. So when you see a patient in that age group that really hasn't had an injury and you have that MRI finding, the way you should look at it is it's one piece of the puzzle. They may have a rotator cuff tear that has nothing to do with their symptoms. They may have a rotator cuff tear that's partly the result of their symptoms, or they may have a rotator cuff tear that has nothing to do with their symptoms. And the trick that we have as docs is to talk to patients, examine patients, look at all the studies that we have, and try to come up with our best theory as to what the cause of the problems are. And the rotator cuff's the poster child for that.
I'm so glad you brought that distinction up. It's such an important point for people to hear, because an X-ray finding has to be correlated with the clinical findings, the person's story. You know, when they fell, did they land on their left arm or their right arm? All those things. When a person falls, did they land on their outstretched hand, or did they injure their face? Did they faint before they fell, in which case they hit those clinical, the story and your exam make such an important distinction. So rotator cuff, I know myself. Luckily, I don't have arthritis yet. If I do, I'm too unsmart to notice it, but I pick up my grandchildren a lot, and some months ago, I thought my shoulder was kind of sore. I thought, I don't want to ignore anything, and it's nothing. But I know that rotator cuffs can happen from even, say, exercising in the gym. My dear husband will say, don't do the sitting, the exercise where you sit and you pull down, because you don't want to do too much of your head. You're a certain age, as you say. Some of these injuries increase with wear and tear on our equipment here. How about bursitis? I remember my dad suffered terribly from that. Tell us about bursitis.
So the way I look at bursitis, it's sort of like fever when you have a viral infection. So the bursa is the structure in the shoulder. The most common one is the structure between the rotator cuff and the bone over it, called the acromion. So it's called the subacromial bursa. And it's a normal structure. It's normally present. It can become inflamed primarily as a result of something like gout or other crystalline arthropathy, infection, things like that. Probably the most common way that it becomes inflamed is as a result of having inflammation from rotator cuff impingement or other rotator cuff problems. So the bursa in itself is rarely the problem in bursitis. Bursitis is typically something that you see in association with rotator cuff tendonitis or rotator cuff tearing or partial tearing, or sometimes crystal disease such as gout.
So bursa, would you describe it as a brake pad?
Sort of like that. It's a sac. There's a bursa in the body anywhere that two structures rub back and forth on one another. And the purpose of the bursa is to provide lubrication in that interface so that there can be good pain-free range of motion without friction. That's what the purpose of the bursa is. But the bursa can become inflamed and actually has a tremendous number of nerve endings. In fact, the highest concentration of nerve endings in the shoulder is the subacromial bursa.
So the most common conditions you see in your office are probably, would you say, rotator cuff injuries, bursitis, or impingement? What does that mean? That something's rubbing on a nerve something's out of place?
Well, to be honest, there's a little bit of a controversy about impingement, subacromial impingement. It used to be that when I started my practice 33 years ago, we thought that, and it was pretty much accepted, that 90% of all rotator cuff tears was a result of impingement of the rotator cuff against the bone over it called the acromion, and that was called subacromial impingement. We now, or I shouldn't say this, there's now a lot of evidence to show that impingement is probably not as important as we thought it was, and there are some people who think it doesn't even exist, that there's no such thing as subacromial impingement. I don't take it that far. But impingement is a term that we use where there's abnormal contact between the rotator cuff and the bone over it called the acromion bone. And as I said, it's a bit controversial at this point, but pendulums tend to swing back and forth. And I suspect that impingement will never leave our vocabulary.
Interesting. And that's why it's so helpful for people to hear you describe that with the thousands of shoulders you've examined. I mean, you probably can't even guess. Well, I'm sure you can guess how many different cases. It's just like me doing thousands of colonoscopies. Everyone is different. Dislocation. Once in a while, I watch the TV shows where the talent shows, that are American or British or something, and you'll occasionally see an act where a person intentionally dislocates their joints. And I think, oh my gosh, how about dislocation of the shoulder? When you see that, or when you see especially young middle schoolers or high schoolers playing in a game and they dislocate their shoulder, what do you tell the coach or people there to do on the spot?
Well, if it actually is dislocated, it probably needs to be put back in as soon as possible. The dislocation can cause damage to nerves around the shoulder, et cetera. So if it really and truly is dislocated, somebody should be seen by a professional, evaluated, and the shoulder should be put back in whenever it's safely possible. Dislocations are sort of weird for the shoulder. And the reason is that, as we discussed earlier, the shoulder acts like a ball and socket joint. So it acts as if it's a very stable joint. But the fact of the matter is it has almost no stability built into the joint. So in order for somebody to dislocate their shoulder traumatically where it comes all the way out and stays out, they usually have to tear something. They usually tear the ligaments or a structure called the labrum. There's usually something irreparably damaged that might need to be fixed. On the other hand, there are patients who are really, really loose jointed. Loose jointedness is something that is a spectrum of things. I mean, I'm the most tight jointed person you ever met. I can't hyperextend any joint in my body. But there are some people who, you've seen them before, where they sit on the ground and they've got both of their legs turned outside, completely flat on the ground.
That's what I mean. And you see people applaud when they do it in a show, and you say, no, that can't be good for them.
So those patients or those people can actually sustain a spontaneous dislocation and reduction without much trauma, not tear anything. And the first person that I described to you, particularly if they're younger and they've actually torn a ligament and it's really not where it belongs, they should do surgery and they have a very good result in general. The people who have inherent loose jointedness, who have instability without a really significant trauma, particularly if there's nothing on the MRI scan that shows that it's not where it should be, in other words, there's nothing torn, those people actually do well with non-operative management, actually better with non-operative management than they do with surgery. So dislocations happen in different people, and it's like everything, even stuff that you see, Marianne, everything that you know of as a pathologic condition comes in a human being, and every human beings are different. And what you're looking at in front of you as a particular pathological problem may have different factors that affect it other than the trauma.
Sure.
If you look at the pathology in that person in the absence of having all that other information, you can sometimes do the wrong thing.
Sure. It's about the whole person and the context in which this has happened. But when you see, especially in little girls in gymnastics class, and some have looser joints than others and can fall right on the floor with a split or do these things with their arms, how do coaches and teachers advise them not to push their luck?
It's a little bit of a double-edged sword, at least in my experience. The loose-jointed people make very good athletes. I'm not really sure why that is, but they seem to. So the way that I would look at those situations is they should strengthen their rotator cuff muscles to help their shoulders to remain stable.
There you go.
And if you try to get them to think about every single motion they put their shoulder in and try to actually have a conscious idea of what they're going to do and when, they actually are more likely to get hurt. So
right.
I basically tell
they're not
them,
spontaneous.
Keep their shoulders strong. Stay away from extreme positions. But for the most part, do what you want to do that doesn't bother you.
Mm-hmm. And of course, fractures are a possibility with any joint or any bone. Let's take a little break, and when we come back, more from Dr. Gerry Williams from Rothman Orthopedic Institute. And welcome back to your Radio Doctor. We're learning all good things about the shoulder, how to protect your shoulder from injury, and the common conditions that our guest, Dr. Gerry Williams, sees in his office. Gerry, the neck and shoulders are very close together. And as Robert Frost would say, good fences make good neighbors. I'm sure sometimes it's difficult to distinguish the source of pain because shoulder pathology can disseminate or radiate into the neck, and neck pathology can cause pain that travels into the shoulders. How do you distinguish, or what are ways? We talked earlier about looking at the whole person, because an x-ray that has a finding doesn't always correlate with the final answer.
Well, let's take it from the standpoint of things that go from the shoulder to the neck. There's not that many of them. In fact, there's pretty good evidence to show that the only area of the shoulder that has nervous distribution that could cause neck pain is around the AC joint, which is the joint that you separate when you fall. So people who have AC joint problems can sometimes have neck pain. That's about the only thing that goes that way. There's a lot of stuff that goes the other way. And as we get older in age, our neck ages too. So when I gave that example earlier about a person that comes in with a rotator cuff tear when they're 75 and you're trying to figure out whether that cuff tear is part of their symptoms or not, the same thing's true in that same 75-year-old patient that comes in with shoulder pain that you might be unclear on because their neck's degenerating just the same way their shoulder is. So what are some of the things that you can pick out to try to decide whether your problem's coming from your neck or your shoulder? The first is whether or not there's any pain that radiates from your shoulder down your arm past your elbow. Almost all rotator cuff or other shoulder issues can radiate down the arm, but they never go past the elbow. So that's one thing. Pain that's around your shoulder blade, periscapular pain, like when where your shoulder blade meets your ribs in the back, that is more often a cervical radiculopathy or a neck problem than it is a shoulder problem. It's not always that way, but it often is. And obviously, if somebody has weakness in their arm, and you can actually demonstrate that they're weak by testing them, but there's no other evidence that you can find, like a torn tendon or something like that would explain weakness, that's often a nerve-related problem.
Sure, that makes sense. And that's why when you examine people too, I would think that if you're always going to examine both arms to see, a lot of times when a person say, and it's a totally different part of the body, but if a person has knee pain, it's because their hip on the opposite side is an issue.
Correct.
And then they're putting all their weight on the good leg, and then they end up with knee pain. And I'm sure that applies, as you say, neck, shoulder, elbow. You're looking at the whole chessboard to understand, and sensory loss is a big clue, certainly.
So the other thing that I failed to mention is as people get older, and we're talking about people that might have neck and or shoulder problems, people are always trying to put people in the pigeonhole of either having a neck problem or a shoulder problem.
Yes.
If you're over the age of 60, which a lot of my patients are, you're more likely to have both rather than one or the other. And the question is how much is coming from where? And we often use injections to try to figure out how much is coming from the shoulder. For example, let's say somebody has an arthritic shoulder, but they also have neck issues. And I'm trying to figure out how much of their pain is coming from their shoulder so I can decide whether or not to treat their shoulder or not. If you inject the shoulder joint and somebody you think has arthritis as the source of their pain in their shoulder and nothing happens to their pain, it's not coming from the shoulder.
Voila.
And the converse is also true. If you think somebody's got a neck and a shoulder problem and you're trying to figure how much is coming from where, if you inject the shoulder and the pain goes away for a period of time, it's coming from the shoulder.
And that's the beauty of somebody having the luxury to see a doctor like you, Gerry. Aside from the experience, that your focus is on shoulder, elbow, and that you've seen so many different presentations of the same thing. And while we're on the subject of having the luxury of a timeline, we practice two very different types of medicine. But the parallel between orthopedics and GI over, 40 years ago when I was a fellow, colonoscopy was just coming into favor. There are a lot of people that still shy away from it. That said, before the beauty of endoscopy, that we could take a peek inside, we did rely on x-ray. So if there was a shadow in somebody's colon on x-ray, we'd send them to surgery. Well, before I was in practice, they'd go to surgery and gee whiz, it was benign. Holy Toledo, we put this person through surgery and lost a portion of their bowel. 40 years later, or I don't know exactly the history of when arthroscopy, so now we can take a scope and look in as though it's as bright as the sun shining inside an internal pathway. You have done magical things with arthroscopy or scope of a joint, surgery in this case. Let's talk about, in the past, you'd have to make a pretty good sized incision, cut the muscles to get in and see your field. Now, with the beauty of technology, you can get into the joint and have a good view and to do magical things. Tell us about that, if you would.
It's interesting. I started my practice in 1990. Mm-hmm. At that time, very few people were doing arthroscopic anything.
Right.
Cuff repairs were done open for the most part. Instability operations were done open. And basically, over my 33 years, arthroscopy has become an extremely common procedure. Mm-hmm. And as you say, you can't really beat the visualization of arthroscopy. I mean, you can put the arthroscope anywhere. You know, you do an open surgery from the top or the front of the shoulder, you can never see the back of it. Whereas if you put an arthroscope in the shoulder, there's pretty much not too many places you can't see. And if you can see it, you can fix it. Mm-hmm. So, arthroscopic cuff repair is commonplace at this point. I can't remember the last time I did an open one. Arthroscopic Bankart repairs or labral repairs are still quite common. We take out bone spurs. We also repair things with an arthroscope. The bottom line is arthroscopic surgery has changed things. However, I will say that, and John Fenlin, whose chair I have the name of, God bless him, rest his soul.
One of my teachers.
He was one of the finest open shoulder surgeons I ever met. Mm. And the bottom line is, if I look at some of his patients that I used to see and follow up and compare with open cuff repair compared to my arthroscopic cuff repairs, there was no difference. The outcomes were spectacular.
Well, that's the paradox here, don't you think, Gerry? People think, gosh, if you can't make a big belly incision. I trained at Sloan Kettering, and I came home to Philadelphia, and I think I was one of the first people, if not the first, who had trained on patients like humans as opposed to animals in a lab. Did 150 laparoscopies, and we could put that little probe in and see the whole world inside the belly. A whole lot more, as you say, than opening and putting our hands in. And people must think the opposite. Gee, you're not making a big open doorway to go in there? Yeah, you can creep around lots of little places.
Well, I guess what I'm trying to say is there's a tendency in every discipline to look at the idea of surgical procedures that disrupt less of the normal structures to accomplish the operation. It makes common sense to most people that would be better, and it usually is. It's done so often, and it's very well accepted, and it's great. All I'm saying is there are certain principles, for example, for a cuff repair, and the principles are the same, whether you do them open or arthroscopically. And the point is, I always tell surgeons that I teach, do whatever you do best. So if you're better at an open cuff repair and you have somebody in front of you that needs a cuff repair, do it open. Do it the way that you know how to do it. It's a good operation either way. If you can do it arthroscopically well, do it well. And if you have to do it open to do it well, do it open.
Another great point from a master. A patient then learns that he or she has to have shoulder surgery. Is that a question that a patient should ask the doctor? Doctor, you're suggesting that I have this cuff repair or whatever the issue. Will you do it as an open procedure or with a scope? And
I think it's a fair question.
People hesitate to ask that. They don't want to offend the doctor, but I I think people know how to ask that in a nice way, or we should, yeah?
Well, I think it's a fair question. I have patients ask me that. So, for example, somebody will say, how many reverse shoulder replacements do you do? Thinking I'm going to say 10 or 15. I said, well, I've done probably 3,000.
Oh,
And that probably catches their attention. On the other hand, I'll give an example in the opposite direction. I had a patient come to my office today who had a strange injury, which I think was a tear of his latissimus dorsi tendon.
Oh.
I think that's what he has. We're getting an MRI scan to be sure.
So for people listening, latissimus dorsi.
That's your lat.
All those, yeah. Oh, gee, that must have hurt.
He had already looked up. He was an attorney. He had already looked up what this was and who fixes it and all that kind of stuff. And he said to me, have you seen this before? Yes. How many of these do you fix? I said, as many as anybody else. There's only one person in the country that fixes a lot of these, and he's in Chicago. And I'll give you his name if you'd like to go there. But if you see any other shoulder expert in the country, it's a handful. This doesn't happen very often.
Well,
so I think it's perfectly fine to have that conversation with people, and I'm honest with them. You know, I tell them, look, I'm here to give you information that's hopefully good enough for you to make a decision about what you want to do.
You make so many good points, Gerry. I can remember people say to me, you know, I'm bringing my mother to see you, or they're elderly and they're frail. And if you find cancer, don't tell them. And I would always say, listen to me. Do you want a doctor who doesn't tell the truth? Or do you want me to be honest, which is only fair to the person in the bed or the person with the sickness? I can explain it gently and say there's hope, and we're going to make sure it's that before we jump onto something drastic. But I think that's really terrific, because then, and I always says if I see somebody and they have questions and they're on something, I say, listen to me. Go see another doctor and get an opinion. Come back to me, but I want you to be comfortable with your final decision. You're just doing your homework, and that's a good thing. And we're encouraging patients to do.
I do the same.
And that's
thing.
the whole purpose of these. I'm sorry.
I do the same thing.
Yeah, it's the purpose of our conversation, so people hear and they know what to ask. We're going to talk a little bit more about the types of arthroscopic surgery and the joint replacements, because I think that's another thing people need to hear. But I think I need to be your talent agent and say that I would guess that you are probably the most experienced shoulder surgeon in the U.S. of A.
I don't know about that, but I can hold my own. I've been doing a lot of shoulder surgery for a lot of years.
Oh, that's awesome. Let's take a little break and hear about this week's champion. And when we come back, more from Dr. Gerry Williams and shoulder surgeries.
Now, your real champion.
And now for your real champion. I call this segment The Beaches of Normandy. January, a time for new beginnings, new goals, new hobbies, new adventures. The chance to try something new, or the opportunity to attempt something that didn't go so well before and try again. It's also a great time to pause and reflect on the year that came to a close and the holiday season we just celebrated. Hanukkah, Diwali, and Kwanzaa all share the symbol of light as a sign of renewal after winter solstice with hope for warmer and brighter days, a sign of wisdom, of good over evil. With Christmas, Christians believe that God himself became human and entered the world humbly as a little baby who would grow into the Savior, who would set the world free of sin and bring us salvation. That was his very special role in creation. Do you ever stop and wonder what your role is in creation? Even Mark Twain pondered when he wrote, "The two most important days in your life are the day you were born and the day you find out why." This past December, I had the chance to visit Paris, France. On one day in particular, we visited the beaches of Normandy, the site of D-Day. On June 6, 1944, almost 160,000 Allied troops from the U.S., Canada, and the U.K. landed on a 50-mile stretch of beach to fight the Nazis. They were joined by more than 5,000 ships, 13,000 aircrafts, to form the largest amphibious invasion in military history, which marked the beginning of the end of World War II. Now, it's one thing to hear about a war in your 7th grade history class, but to see the stretch of beaches and come to realize that these young men landed, and when the ramps opened, they walked into shallow water facing multiple layers of Germans entrenched in bunkers on hillsides aiming machine guns known as Hitler's buzzsaws, which could shoot 1,500 rounds a minute. Allied soldiers were systematically mowed down, with over 9,000 killed or wounded that day. Videos capture the ocean turning red from the blood of boys who weren't even old enough to vote. Those who perished included 2 women, both British nurses. Again, I emphasize young, high school-age boys. Of all the facts I heard on the tour, the most chilling takeaway was that many of those who died were under age 18. So passionate about serving their country, they lied about their age to enlist. The youngest boy to die was only 15 years old and served as a cook on his boat. And I'll never forget the image of the American cemetery at Normandy, the first American cemetery on European soil in World War II, with graves of 9,389 of our deceased military. A magnificent and pristine memorial park where each soldier, sailor, or airman's grave is marked with a cross or a Star of David. These were men who saw their role in creation as defenders of freedom. They loved their own country, and to protect the oppressed of Europe, they walked into the jaws of death, making the ultimate sacrifice. That day at Normandy gave me a whole new meaning of the greatest generation, especially when I saw the videos of soldiers now in their 90s recount the memories from that day and cry each time they would retell their stories. Inspired by their humility, I rode the bus back to Paris and suddenly realized it was December 7th, the anniversary of Pearl Harbor, and I was overwhelmed with a sense of gratitude. Just as the ocean water ebbs and flows on the beaches of Normandy, life is a series of cycles. Each new year, each new season, and don't forget the opportunity that's right in front of you, the chance to start fresh every single day. From the time I was small, if I had a worry or a sadness, my father always reminded me to put the worry aside and go to sleep, so I could wake up to a brighter day and things would seem much better. So use this first month of the year to pause and reflect. I often repeat to my own children that I don't know how much sand is left in my own hourglass, so I'm trying to use my time wisely. Think very carefully about your own role in creation and ask, why am I here? Am I using my gifts? How can I focus more on the positive? We salute the men and women of our armed forces, your real champions, patriots from the past, the present, and the future, and thank them for securing the freedom that we enjoy every day.
Welcome back to your Radio Doctor. We're here with Dr. Gerry Williams learning about shoulder injuries and shoulder repairs. Shoulder surgery has advanced exponentially, Gerry, as you told us, just like fiber optics that help us do GI procedures, pulmonary procedures, all kinds of procedures with the delicate nature of a scope that could travel into little places that we couldn't get with our big hands and scalpels. Shoulder replacements. A shoulder replacement means we're going to put an artificial joint where your ball and socket used to be. And there are two really important distinguish, and this is, I know the shoulder in general is your baby, but you are Mr. Reverse shoulder as replacement as well. Let's talk about shoulder replacements in general, and then I want to give you time to talk about the definition of reverse shoulder replacement, because I think a lot of people think it means you've had a replacement and now you have it reversed. It doesn't mean that.
No, that's correct. Shoulder replacements really became popular and started to become popular right around the time I finished my residency. So that would have been around 89, somewhere in that ballpark. The first one, however, was done in the United States in the mid-50s in New York.
Wow.
And the original ones that were popular in the beginning were all anatomic replacements, meaning that the new ball was placed where the old ball used to be, and the new plastic socket, if one was used, was placed where the old socket was supposed to be. And the theory behind anatomic replacements is to reconstruct the joint anatomically, put in the right size humeral head in the right place, or the right ball in the right place, exactly where it belongs, and the same thing with the socket. Loosen up the joint so it moves better. It's generally done by taking down and reflecting one muscle and putting it back. And when I first started, there was really only 3 shoulder prosthetics available, one of which my mentor invented. Now there are probably 15, 20 anatomic shoulder replacements. And I think some would argue that some of the changes that have occurred have not necessarily advanced things tremendously. I'm a little bit more of an optimist. I think everyone that we have has come up with something that's a little bit different, and I think it has contributed to the wealth of knowledge that we have with shoulder replacements. However, there are 2 things that have made anatomic shoulder replacements difficult. One is you really have to have a very good rotator cuff, both preoperatively and postoperatively. And the plastic socket is the part that wears out. And it wears out, we got probably a 90% survival rate at 10 years, 80% at 15, probably 75% at 20, which is not like hips. So the reverse shoulder replacement was invented in the mid to late 80s by a guy named Paul Gramont in France. And the idea was to put the ball where the socket used to be instead of the socket where the socket used to be. So we put the ball on the shoulder blade, and the socket goes on top of the arm. And to avoid a really long explanation, the rationale behind that was to create a more stable situation for rotator cuff deficient shoulders. There were reverse shoulders tried before that one that had different kinds of designs, and they failed miserably, which is one of the reasons why we had a very difficult time getting them into the United States. They were using them in Europe from the late 80s on, and we didn't get them FDA approved in the United States until 2004. But the bottom line is the reverse shoulder replacement has caught wildfire, and in my opinion, it's used too often. I think it was invented for people with deficient rotator cuffs with arthritis, and it works great for that patient population. There's controversy about whether or not reverse shoulders or anatomic shoulders are best for people with intact rotator cuffs. My bias is that the anatomics are better, unless you either have a rotator cuff tear that's full thickness and maybe even large full thickness, or the amount of bone deformity that you have, the severity of the arthritis is so bad that it's hard to reconstruct well with an anatomic prosthesis. But in the United States now, more than 50% of shoulder replacements are reverses. When I started, there was no such thing as a reverse. And in 2004, when it first started in the United States, probably 10% were reverses. So it's really taken off. And I think there's some rationale for that, but I personally think that we've overemphasized reverses, quite frankly, in my mind.
So if somebody's just tuning in now, we're talking about shoulder surgeries, shoulder replacement, when we replace the original joint with an artificial joint. And we picture a shallow garage or shallow socket in the ball of the humerus, the funny bone, I guess that's what they call it, the funny bone. The humerus or upper arm bone, the ball fits into the socket. And so when somebody has a reverse knee replacement or reverse hip replacement, it means they take the old joint out when it's worn out or become injured or something, and it's you take the joint out. A reverse shoulder replacement means that the artificial joint itself is the opposite design. Instead of putting the ball on the top of the humerus and the socket where it was originally, you reverse them. So you're saying that usually you decide to do the reverse when somebody has an intact rotator cuff, and that's the more ideal, the opposite.
A deficient rotator cuff. So remember, if we go back to the beginning, we talked about the original shoulder anatomy. We said that it looks like a basketball on a teacup saucer rather than a cup. And the rotator cuff is what keeps the ball centered on the cup. When the rotator cuff doesn't exist or it's really deficient, when the arm gets used, it tends to slide around on the teacup saucer rather than staying centered. So you actually mentioned a minute ago the deep socket. The whole reason that it's reversed is because the surgeon who invented it knew that they needed a deeper socket in order to control stability with rotator cuff deficient shoulders. And the shoulder blade did not have enough bone to figure out a way to put a deeper socket in it. So we had the unique idea of putting the socket where the ball used to be, because there's enough room in the humerus to put a deep socket, and put the ball where the old cup used to be. So that's the whole idea behind it, to create a deeper ball and socket joint to make it more stable with cuff deficiency.
And Gerry, about how long do shoulder replacements last? You started to mention that.
Well, I'm going to give you my experience, because you'll see different numbers. But I tell my patients that they should expect 15 to 20 years with an anatomic one. And I've got some that go longer than that, but I think they can expect 15 or 20. And I tell my reverses they probably should expect 40.
Wow.
The problem with the reverses is they don't have as much of a range of motion. And there's one complication that you get with reverses 4% of the time that you don't get at all with anatomics, which is a stress fracture of the shoulder blade.
Interesting.
So I tell patients that in my experience who need a reverse, they can expect it to last longer, not work quite as well as their original shoulder did, and they have this one complication that we have to worry about called a stress fracture.
The other quick question, as you were describing the replacement, if you picture the shoulder girdle and there's a socket on either side, how do you get that, say, in the anatomical? It fits the way you were created, and you put the socket where it was originally in the ball, the top of the humerus, or the upper arm bone. How do you get that socket to stay in the old socket to me? You glue it in, correct? How could people envision that?
We use something called bone cement for most of them.
Cement.
And it's basically a grout, like you're putting tile on your floor. It fills the interstices, but it's not, in other words, it's not a glue. It's a grout.
I meant to say
so
cement, yeah.
A combination of immediate fixation with what you put in, with more long-term fixation with bone growing around it. When we first started, they were all plastic sockets. There's now been a move towards a hybrid type fixation with perhaps a metal post in the middle to get permanent bone fixation to the implant. There's even some metal-backed glenoids, which are not FDA approved in the United States, but have at least the option of getting more permanent fixation of the socket to the bone. Because the problem with anatomics is lack of longevity for the plastic socket.
And that's the reason I was asking, because you think plastic must have you talked about 15 to 20 versus 40 years with the reverse. And I often thought, as all of these technologies have evolved, I know there's a hip replacement that was coming around in the, 15 some years ago, the Birmingham hip, and it seemed like it had the pluses, but then you're worried about metal ions in the blood. And, when something new comes along, we say, yay, let's do this. And then when it's around for a while, we do thousands of people. We're constantly learning, and the whole technology is evolving. But it's really cement that keeps it in place. And it's kind of interesting. Maybe that's why the reverse replacement lasts longer, because it does have less range of motion, and the person's less likely to not abuse it, but go too far.
Well, the reverse acts like a hip joint. It actually is a true ball and socket joint, so there's no sliding motion at all. So the wear on the polyethylene or the plastic is much less in a reverse than it is in an anatomic.
It's so cool. Let's take a little break, and when we come back, our wrap-up with Dr. Gerry Williams from Rothman Orthopedics. Welcome back to our final segment of Your Radio Doctor. A very big thank you to you, Dr. Gerry Williams, for talking about shoulder injuries, shoulder repairs. What's your take-home message for listeners?
Well, the best way to manage shoulder problems is to not get them. And unfortunately, there's probably no way to avoid them completely. If you look at young people, they're going to do stuff that's a little crazy. Some of them are going to be crazier than others, and you're not going to change them. So the best you can do is tell them to stay in shape, keep their muscles strong, stay flexible, and use their head as much as they can. As we get older, I think you do have to factor in the fact that your muscles and your tendons and your joints are not quite what they used to be. So warm up before you do a significant amount of exercise. If you're going to do something new, don't jump into the deep end. Start off slow and work your way into it. And if there's something that just looks like it might be a little stressful or more than you want, don't push yourself any more than you're comfortable with. Now, as you mentioned a little bit earlier, pickleball is huge right now. And what I see is the biggest problem with pickleball, and we do see a lot of people with pickleball injuries. Most of them have to do with the fact that they're people who really have spent no time keeping themselves in shape. They decide they're going to start this new game, and they try to play it like they were 20, and they're really 70. So what I would say to you is if you decide you're going to pick up pickleball at some point, and you're not quite in the best of shape, get on a bicycle and do some exercise, get yourself in a little bit better shape, and maybe work your way into it. So I think if you just use your head a little bit, I think it'd be good. And I think inactivity is bad. Yeah. As we get older, I think staying active and keeping your muscles and your joints and your tendons working is a positive, not a negative.
Well, I think the whole pickleball misconception, too, is people think they're playing a little bit bigger board game than ping pong because it's so close. I mean, tennis is this big and paddle is this big and pickleball, it seems really easy, but there's more torque and more craziness, and people just wear shoes they have around the house. You need the right shoes and eye coverage and all that good stuff. So good information there. And be careful with shoveling. Obviously, we're not... anybody can be injured with shoveling snow. One of the things I used to do, and I never thought about it, and sometimes you see it in a commercial, somebody's in a hammock, don't sleep with your arm over your head. I don't know why. I'd get into bed at night, and my husband would take my arm down and say, you're going to hurt your shoulder. And I never did, but I know it's in my brain not to do that. Do you think that's a common way, or people fall asleep on their belly with their shoulder up?
Most of the patients that I see that have trouble sleeping on their shoulder. And if you have somebody that you think has a shoulder problem and they tell you that they sleep well on their shoulder, they probably have something else.
Interesting.
That's usually the thing that bothers people the most. And I think keeping your arm in an extreme position, no matter where it is, for a period of time is probably not good for it.
Any certain jobs that lead to shoulder injuries more than others? I'm sure if you're a UPS man or you're lifting heavy packages, but any overuse?
Construction workers, stuff like that. Anything that's tough on the arms. But, to be honest with you, many of those jobs pay well. The guys that I used to have the hardest time trying to slow down were UPS workers, FedEx workers. Those guys get paid by how many packages they deliver. Sure. And they get paid well.
Yeah. Well, and you bring up a good point, too. Time plays tricks on our ligaments and joints and all those good things. And arthritis aside, even if you don't have it, staying in shape has so many valuable features, because just having the strength, you watch people become semi-retired or tired and go to a gym and start using machines themselves without advice. Oh my gosh, you must see injuries from that. And it's not just, as we said, somebody will sit down and they'll do a pull down. Push-ups, pull-ups, military press. I was making a list of things I see people do in the gym. Not that I'm faithful and then I fall back, but I'm trying to go and work out. Or arm people that lift weights and hold them out, extended. That can be tough on your shoulders as well, yeah?
The biggest one for us is bench presses. Anything that looks like a bench press, like a push-up. And the classic story is a guy that was 30, was a big-time muscle builder, right? And then at 60, he hadn't worked out a lot, but he's going to decide to get back in the gym. And he wants to see after 3 weeks whether he can bench 400 pounds. Bad idea.
Well, I have 3 kids, and they like to see their mom and dad healthy. They say, Mom, you got to work out more, and you have to do it till it hurts. People have to learn that when you exercise, that you don't exercise until it hurts isn't always the way to no pain, no gain. It's not a good adage to follow. Lastly, Gerry, is there a website where you can send our listeners where they can read more about protecting themselves from shoulder injury, how they'd recognize shoulder issues, and where they go for advice?
So RothmanOrtho.com is our website, and there is some information there. There's a lot of information. The American Academy of Orthopedic Surgeons, which is the largest organization of orthopedic surgeons worldwide, has a website called orthoinfo.org. Either org or com. Orthoinfo. I think it's orthoinfo.org.
Well, I'll triple check and put it on our website as well.
Bottom line is almost anything you could think about orthopedically that you need information on will be there.
And it's just like some of the websites we often recommend, like the American Cancer Society. They're written so clearly with diagrams. It would be great for people with any questions about shoulder to look at these websites. Orthoinfo.org or .com will bring you to OrthoInfo. And look at a picture of a reverse shoulder. So when you do go to your doctor, you know what to ask.
Yep. I agree with you 100%.
Well, Gerry, thank you so much. Happy New Year to you and your family. Such a treat to have you on the show. And
thanks for having me.
And don't shovel. Call me. I'll come and shovel your walkway for you.
I'm not home enough to shovel it.
Thanks, Gerry.
All right, good deal. Thank you, Marianne.
Thank you for listening to Your Radio Doctor every Saturday afternoon at 5 here on Talk Radio 1210 WPHT. Listen to all of our shows again on Odyssey.com, AUDACY.com. And now you can listen and watch every show on YouTube. Visit Your Radio Doctor on YouTube and give me a Happy New Year when you subscribe to my channel. YouTube. Search Your Radio Doctor and please click on subscribe. A very big thank you to all of my listeners who generously donated to Diapers for Darlings, our campaign to provide diapers and supplies to needy mothers. There are so many people struggling right now, and every little bit you give is a big help. We ended our campaign in December with over $5,000 in gifts, so thank you, and we'll be collecting again in the spring. And this is a special invitation to all of my listeners. Send a message to info@yourradiodoctor.net. Let me know about a health or medical topic you'd like us to cover, a champion we can highlight, or if you'd like to partner in the show as a sponsor. Again, a message to all of my faithful listeners. Send a message to info@yourradiodoctor.net. Please pray for all the people suffering right now, people left homeless from the fires in Los Angeles, those still displaced from the hurricanes in Florida and North Carolina, our neighbors right here in the city of brotherly love, and those who are sick and those who are lonely. We continue to pray for peace in our world, peace in our beloved country, in our families, and in each of our own hearts. This is Your Radio Doctor, Dr. Marianne Ritchie, wishing you a happy, healthy, and safe new year with the ones you love, and always here to remind you that your health is your wealth.
Thanks for listening to Your Radio Doctor, Dr. Marianne Ritchie, presented exclusively by Independence Blue Cross. To contact Dr. Marianne and to listen to today's show as well as past shows, visit yourradiodoctor.com. This program is paid for by Your Radio Doctor, LLC. All opinions or statements expressed on this program are solely those of Your Radio Doctor and their guests and do not reflect the opinions of WPHT or Odyssey. Today's program has been pre-recorded.